Good morning and welcome to Chapter 3 of our pathology course. This week we're going to look at the respiratory system, which you guys know that you're going to be imaging all the time with your chest x-rays as well as some other soft tissue necks and different airway procedures. So hopefully that this will get you a little bit more comfortable with some of the pathology you're going to be seeing and make you more confident in your imaging. Please take a minute to review the chapter objectives as well as the key terms on slides 3 and 4 to make sure that you're going to have your attention drawn to some of the critical points throughout this PowerPoint. Please take a minute to review the chapter objectives as well as the key terms on slides 3 and 4 If you look at the structure of the respiratory system itself, we breathe in through our upper respiratory system or our nasal or oropharynx part of our body, and that air travels down through our trachea into our mainstem bronchi, into the tertiary bronchi, and eventually out into the alveoli. And it's at the alveoli where we're going to have that oxygen carbon dioxide exchange, and where the blood is going to be oxygenated and the waste is going to be removed, and then of course exit out the same respiratory system. We're also going to be evaluating some of the internal devices that you may see on your chest radiography. Some of those you're probably familiar with, such as an endotracheal tube, which is inserted to help a patient breathe, central venous catheter, which helps deliver medications to a patient, a Swan's-Ganz catheter, which can evaluate pressures, and a transvenous cardiac pacemaker, which is to help maintain a consistent heart rate. This is an image that demonstrates appropriate endotracheal tube placement. So you'll see a radio-opaque line, which is a line that they produce the endotracheal tube with, so it can be better identified on radiographs. And you'll see that radio-opaque line advancing down the center of the radiolucent trachea because it's filled with air, it's radiolucent, and you'll see it ending just about 5 centimeters superior to the carina. So we see the carina right there at the inferior portion of the bifurcation of the right and left mainstem bronchi, and you're looking to have the end of that endotracheal tube about 2 inches or 5 centimeters superior to the carina. Excessive advancement can cause issues to the patient. Inadequate advancement can also cause problems for the patient's breathing. So having this in appropriate placement is going to be very important. In addition, on the same image, you'll see to the patient's right-hand side that they also have a central venous catheter. This catheter has been advanced through their subclavian vein down into their superior vena cava and terminates just proximal or just superior to the right atria. That allows easy vascular or venous access for quick administration of drugs to a patient or large boluses. Here we see an example of an improper central venous line placement. So you will notice on the patient's right-hand side, you see a radio-opaque line coming in the subclavian vein. Rather than going down into the superior vena cava, you see it actually going up the internal jugular vein. So this patient, this is an improper central venous line placement. Now, what you look to the patient's left and you see something with a radio-opaque stripe that you could mistake for a misplaced endotracheal tube. Now, this one, because you see it going down the patient to the left lateral side of the trachea, you know that this is actually in the esophagus rather than the trachea. You see it advance all the way down anterior to the heart, and you should see it terminate below the diaphragm. That would indicate that this would be a properly placed nasogastric tube. The reason it can do this is because if the termination of that endotracheal tube is before the separation of the esophageal system and the tracheal system, air can not only be entering the tracheal system, but the esophagus as well, and therefore you would see that air entering the stomach. Now, if an endotracheal tube is advanced too far, it's more common that it's going to go down the right main stem bronchi because of the more vertical placement of the right main stem versus the left main stem's more horizontal placement. If we look at the central venous pressure catheter, this is a catheter that's introduced into the venous system, typically through the subclavian vein, and it has a tip on this catheter that should end in the superior vena cava. So it would go through the subclavian into the superior vena cava, and it would terminate usually again just superior or just proximal to the right atria. Now, with this one, some of the things that can go wrong is rather than taking that inferior turn to go into the superior vena cava, it can take a superior turn and go into the jugular vein. It could also be advanced too far. So it's on the right track. It goes through superior vena cava into the right atrium. And if it's advanced too far into that right atrium, it can cause arrhythmias or perforation of the heart. One of the complications with this is also a pneumothorax because they are introducing a catheter very close to the apices of the lungs. It is possible to have a pneumothorax. In addition, infusion of fluid into the mediastinum or pleural space can occur if they had pushed the catheter outside of the venous system into the pleural cavity. Then those are issues you may see. A Swan's-Ganz catheter, this one's a little bit harder for me to remember. So one of the easiest ways, I think about a swan floating. And with the Swan-Ganz catheter, what it does is it basically introduces a catheter to the right or left main pulmonary artery. And it's able to do that by coming through the similar system of our central venous catheter. It will go through the subclavian, usually superior vena cava, into the right atria of the heart, the right ventricle, and then it will float like a swan up into the pulmonary artery. One of the complications with this is a pulmonary infarction, especially if it's advanced too far. There's also a transvenous cardiac pacemaker, which is introduced into the heart through the venous system, and it's a pacemaker which would then control the rhythm and electrical system of the heart. Now, with a transvenous cardiac pacemaker, sometimes we need to actually overexpose the image to try and identify the tip of the electrode, and we should be seeing those electrode tips at the right ventricle. If this is improperly placed, those tips can go through the right ventricle and actually exit into the cardiac blood flow and be noted in the coronary sinus of the heart. So the cardiac blood flow would be the blood flow not going through the heart, but the blood flow actually feeding the heart. Part of that is the coronary sinus, and misplacement may result in the tip being noted in that coronary sinus. The other thing can be perforation of the heart during an initial insertion. This brings us to some of the diseases of the respiratory system. And we're going to look first at our congenital or hereditary diseases. And remember, congenital means something that you're born with, and hereditary means something that is attached to your genes. So if you have something attached to your genes, it's obviously going to be congenital because it's something you're born with. However, not all congenital diseases are hereditary. Sometimes it's just something you're born with, but it's not associated with your genes. Cystic fibrosis is an example of a congenital and hereditary disease that will affect, ultimately will affect mucus production and ability to excrete mucus throughout the body. Hyaline membrane disease is another congenital disease. This one is not hereditary. Cystic fibrosis is one of the leading, most damaging diseases noted in white children currently. So cystic fibrosis is an imbalance of sodium and chloride, which causes a thickening and difficulty to move mucus throughout the system. It is a congenital disease, also hereditary. The problem with this is that there's a defective gene in chromosome 7, which causes the imbalance of sodium and chloride. Because of that sodium chloride imbalance, mucus in the body tends to get thicker and not be able to be removed as easily as it is in a normal healthy person. So with cystic fibrosis, what happens a lot in the chest is that normal mucus that we can typically cough up and move on actually stays in the upper and lower respiratory system because it's so thick they can't cough it out. Because of that, anytime mucus is sitting in a warm environment for a long time, it's going to be more probable to cause bacterial infections. And so with these patients, it's really common for them to have significant bacterial infections, which then can go on to cause abscesses and other more significant pathology. Another problem is that the mucus is so thick it can get wedged into one of the bronchioles and cause a lack of ability to move air through that area, and eventually that lung tissue will collapse because of the pressure changes. Another area that the cystic fibrosis really affects people is in the endocrine system. So in the endocrine glands itself, as well as in the bowel, it will actually produce that thickened mucus affecting the function of those organs. One organ of the endocrine system that it has some very negative effects on is the pancreas. The pancreas can become very bright on imaging, and it can be very condensed with mucus. That condensation of mucus within the organ will prevent it from being able to pass its necessary digestive enzymes into the bowel. Ultimately, that causes the bowel's ability to break down fatty foods to not work as efficiently. And so these patients will often have a failure to thrive type of appearance. So where they're thin, they can't put on weight, and that's because their body's not able to break down fats and absorb them. The other thing it affects is going to be their bowels. So bowels, we know, have a lot of mucus in them. So it's going to cause a thickening of that mucus as well. It can lead to bowel obstructions and other issues. Most cystic fibrosis patients, historically would die at a very young age. They're getting some more advancements in ages now just because using chest physiotherapy, they have vests that these patients can wear that shake them and try and break up the mucus so they can cough it out better. They have medicinal and DNA type treatments to help with that thickened mucus problem. One of our imaging appearances on a chest x-ray would be radiographically irregular thickening of the linear markings throughout the lungs. As I mentioned, you can also, if there is an airway blockage because of mucus, you can also see atelectasis or lung collapse. In abdominal imaging, you might see a radio-opaque pancreas because it's more attenuative than a typical pancreas would be. So those are some of the things that we're seeing on imaging. Because of the advances in treatment, now we're seeing patients make it into their 30s sometimes, which is a big improvement from previously. Hyaline membrane disease is a congenital disease. Now, this one is not hereditary. It's something that the fetus is born with or the child is born with, but it's not attached to a genetic problem. So it's congenital but not hereditary. With this disease, it's also known as idiopathic respiratory disease system. Idiopathic, remember, means we don't know why. However, most of these children born with this problem are actually born premature and often to diabetic mothers. And it is estimated that the problem really lies in the fact that these early or these premature babies have not had the time to produce enough surfactant. And surfactant is the material or the fluid between the parietal and the visceral peritoneum in the chest that causes the lungs to stay basically provides tension between the lungs and the thoracic wall to maintain an open lung airway. With the hyaline membrane disease or IRDS, that surfactant is not as mature, and so it may be it can cause that tension between those two layers to be less effective and can cause to respiratory distress. So one of the things that you'll often see is a baby might be born, they may be seen fine, but within 6 hours of birth, they can start demonstrating respiratory distress. Hyaline membrane disease, one of the things that you will often see on your chest x-rays is under aeration. So you won't get the lung extension that you typically expect. The other thing is that you may see possibly more radio-opaque lungs. So you'll see an increased density across those lungs. And sometimes that can be caused from atelectasis, where the lungs are actually collapsing in on themselves. And it can lead you to be able to see the trachea and bronchi and bronchioles better as like the airway tree, because now those radiolucent bronchi are going to maintain a black appearance, and that black appearance will be contrasted by the increased radio opacity of these lungs. So here's just a quick review chart for cystic fibrosis and hyaline membrane disease. One thing we didn't talk about was the treatment for our hyaline membrane disease. One of the ways that they can treat this is by providing an artificial surfactant to the fetus and putting them, or pardon me, to the baby and putting them on positive pressure ventilation. And so those are the congenital and hereditary diseases most commonly seen in the respiratory system. Us to croup and epiglottitis. These are two types of inflammation disorders in the upper respiratory system, meaning in the nasopharynx and the trachea. So croup is something you often hear about in babies. Epiglottitis has kind of a similar symptom process, and so we'll talk about those more. Croup is typically identified through a barky cough in young children and infants. It's caused by an inflammatory process that causes swelling in the subepiglottic portion of the trachea. So just before the epiglottis, where the trachea and the esophagus originate, just below that area, there's inflammation causing swelling, and it results in a very barky type cough. This comparison image, you can see the difference between somebody with croup and somebody without. On the right, you have a nice open subepiglottic area where air is moving normally. On the left, you see a narrowing or a restriction at that area, and that's what results in the cough. Epiglottitis is similar in that it affects children, and it is an inflammation process. This one is, as the name indicates, it's the inflammation of the epiglottis itself. So croup is the trachea just below the epiglottis, whereas epiglottitis is inflammation of the epiglottis itself and the surrounding pharyngeal structures. So this has been lessened due to vaccinations of children, but again, it can cause a cough and other symptoms because of the inflammation of the epiglottis. With epiglottitis, this is something you typically see on a lateral soft tissue neck, and rather than the normal epiglottis here, you will actually see a rounded, wide epiglottic area due to the swelling from inflammation. For the upper respiratory inflammation, we're going to look at that inflammation reaction in the lower respiratory system. And some of the pathologies that include that lower respiratory inflammatory reaction are pneumonia, anthrax, lung abscesses, tuberculosis, pulmonary mycosis, RSV, or severe acute respiratory system, SARS. The most common lower respiratory inflammation you're going to hear about and see is pneumonia. So pneumonia can have multiple different causes, but it's anything, typically bacterial or viral, that will come into the respiratory system and cause a reaction in that lower end of the system. So with pneumonia, we can have a few different types. The first type we'll talk about is our alveolar or air-space pneumonia. With this, it's going to have a bacterial infection or a viral infection that affects the lungs on the alveolar level. That alveolar level, as you remember, is where blood oxygen gas exchange occurs. And so at this level, there are those small, thin sacs, and they often end up filling with fluid or infection or inflammatory process. And when they do that, they take on a consolidated or a radio-opaque appearance. As they take on that appearance, when you're looking at a chest x-ray, you'll see it demonstrated through what we call an air bronchiogram. What an air bronchiogram is when the lung tissue or the parenchyma or alveoli themselves become more dense, they absorb radiation more, which makes them more radio-opaque. When they become more radio-opaque, they make the bronchial system appear more radiolucent. Now, the bronchial system hasn't changed. It's just the surrounding lung parenchyma that has changed and makes that bronchial system stand out and look more black or radiolucent. Another type of pneumonia is bronchopneumonia. So with bronchopneumonia, it's kind of what it says it is. The inflammation is going to appear or occur in the bronchi. Now, this won't necessarily affect those alveoli so much, so the distal or the lung tissue looks more normal, and yet the bronchi is where the infection is. If the infection becomes significant enough in the bronchi that it blocks one of the airways, that will change the pressure within the lung, and you may see lung collapse or atelectasis in that area. And then finally, there's interstitial pneumonia. And interstitial pneumonia is occurring in the tissues of the lungs themselves, not necessarily in the alveoli, not necessarily in the bronchi, but in the overall tissue of the lungs. Now, that being said, it can spread into the bronchi and the alveoli. So one of the appearances that you might see with an interstitial pneumonia is that you might see consolidation of alveoli and then some normal spared alveoli. And as you do this, as you see these normal and abnormal areas, you can make it appear to look like a honeycomb type appearance. The treatment of pneumonia is going to be dependent on the cause. If it's a bacterial pneumonia, obviously you would use antibiotics. If it's viral and it's early enough, they may use an antiviral. Here you're seeing a bronchial pneumonia, and so you're lacking that air bronchiogram sign that we see with alveolar pneumonia, and instead you're seeing a consolidation of tissue in the right lung, and consolidation is going to mean that radiopaque look. In some of these cases, you'll also find that atelectasis with this. Here is a cross-section of a CT at about mid-chest or the base of the chest, and you're seeing a consolidation in that left lung, again indicative of bronchial pneumonia. Yeah, another pathology that you don't hear a lot about anymore is anthrax. So anthrax comes from byproducts of animals. And so in the 70s, they got pretty good control over the cleanliness and the exposure to these animal byproducts that would cause anthrax. In 2001, you heard anthrax come back again because it actually was utilized as kind of like a bioterrorism type material. And so anthrax, it's usually a white chalky type substance that's created from Bacillus anthracis. It can survive in decades of a soil without a host. So it usually comes from animal byproducts, and then it can just live on for a very long time. Now, there's 3 different types of ways that you can get the anthrax within the body. The first way would be a subcutaneous exposure through open skin. The second way would be inhalation, which is actually the most deadly kind. And then the third way is going to be gastrointestinal, that would come from usually eating one of those contaminated animal byproducts. Anthrax does cause an inflammation in tissue, and it will cause a cellular distension and edema. And with that, if not treated right away, up to 75% of people with lung or the inhalation exposure can die rather quickly. They'll start out with symptoms such as normal flu type symptoms, and then they progress very rapidly from there. Anthrax exposure will usually be demonstrated as a widening of the mediastinum, and then it will result in pleural effusions or fluid between the layers of the parietal and visceral peritoneum of the lungs, and they will collect fluid there and demonstrate a pleural effusion. Most often it won't be associated with any infiltrates within the lung parenchyma itself, but that is possible. Lung abscesses typically occur when there's some sort of inflammatory infective process in the lung, and the immune system is not winning. So there's the battle between the immune system and the pathogen, and as this battle goes on and affects more and more area, if it's not resolving, then what usually will happen is a fibrous capsule will develop around that inflamed area to kind of keep it in one place. As that happens, there can often be some necrotic area within the abscess itself where those white blood cells and the pathogens are kind of fighting out this battle. Ultimately, it's going to produce a pus-like or purulent material within the abscess, which is basically a breakdown of those pathogen cells, pathogens along with your white blood cells and other fluids involved in the attack of that inflammatory process. One of the most common causes of our lung abscesses is aspiration or aspiration pneumonia. So aspiration is when, rather than when you take in food or a liquid and you swallow it, it should go down, it should be turned by your esophagus and turned by your epiglottis and directed down your esophagus into your stomach. If the swallowing process is not functioning properly, that epiglottis won't close to cover the trachea, and that fluid or food can come down the trachea. Now, most of the time, your aspiration is going to occur in the right lung, again, because of its more vertical axis that it's located on. So most of these aspirations are going to occur in the right lung. If they do not identify this early enough or remove the aspirated material, that's when your lung abscesses will develop. These can also be, they can grow and become more proliferative because they often have access to air. What you see in patients with lung abscesses is they're going to have an elevated white blood count because of the infection process going along with this. They'll also often have very foul-smelling sputum and a fever. And so these need to be treated early, and they can be removed or drained. They can have antibiotics introduced into the abscess itself or be on heavy-duty IV antibiotics. An example in the patient's left lung apex of an abscess, and you'll notice that it's surrounded by a fibrous capsule, and it has an overall spherical type shape. Here's an example of the patient's right lung abscess, and you'll see again it has a spherical shape. You'll notice that it has 2 levels of attenuation within that area. The radiotranslucent area is most likely air produced from necrosis of material in there, whereas the slightly more radiopaque area is going to be the purulent material. And go ahead and take a moment to go ahead and review some of these inflammatory processes of the lower respiratory system. Again, these are things you're going to come across frequently, especially when we look at the pneumonias and possibly the abscesses. So be familiar with how they function and what you're going to be seeing when you encounter these. Tuberculosis is a pretty well-known disease, and it's caused by Mycobacterium tuberculosis. And we refer to these little Mycobacterium as bacilli. And bacilli can be transmitted through air as droplets, or it can come up as dry droplets. It can come up, it can be re-emitted as a dust particle. It can also be transmitted through a cow's milk that has tuberculosis, although the issue of that occurring has really decreased as we've started pasteurizing milk. So that is a good reason to buy pasteurized milk. When somebody is exposed to tuberculosis, their reaction is really going to depend on the amount of the exposure as well as their resistance or their ability to fight off the exposure. That rod-shaped tuberculous bacterium or bacilli can be protected by a waxy coat, which makes it difficult to attack. When it gets into the lungs, what will happen is there will be an inflammatory process around this bacilli where it's going to try to attack and take over the bacilli with our normal tissue. When that happens, it actually creates a fibrous shell around this called a tuberculin. Now, if it goes well and it's a small exposure and you have a good reaction to this, usually it will be stopped at that one area and it won't proceed. If, for instance, however, you have a compromised immune system or the exposure was extremely large, then you might have these tuberculins or these areas of different tuberculous infections that may start communicating. The other thing that can happen is if the infection within that encapsulated area is greater than the immune reaction, then you can start seeing areas of necrosis causing an issue called caseation. Now, caseation comes in or appears as a Swiss cheese type of appearance. It's going to have areas of necrosis that's going to be more radiopaque with areas of infection, and so it will have this abnormal appearance that way. As you get multiple areas of infection, they may even start communicating, creating large areas of caseation. If they affect blood tissue, vascular tissue in the area, then they can cause hemoptosis or coughing up blood, which was fairly common when you look in the history of tuberculosis. So this is one of those diseases that your reaction to it is really going to be dependent on your status of your immune system. So somebody previously in years past, if somebody with HIV or AIDS got this, it would probably be a death sentence, where somebody that was relatively healthy could fight it pretty well. But us as radiographers need to be really careful because we can be exposed to these patients and it is a serious infection. So make sure that you're using an N95 mask if you're going to be next to a tuberculosis patient. Primary tuberculosis is the result of an initial exposure, and most of the time we are going to see this usually start out as a single area of consolidation, which will usually occur in the apices of the lungs. If we're going to image this appropriately, then one of the great views to take is a lordotic view to see the apices of the lungs with no superimposition of the clavicles. If it is controlled in this area, sometimes you'll see calcifications around the tubercle that surrounded the bacilli and overcame it. Now, you'll see on the image on the right that this is a patient that obviously it may be from a primary infection, but they have not just attacked and taken care of this exposure. So this is an example of numerous caseous type consolidations that are kind of joining together and creating abscesses. The other thing that you might see with tuberculosis is a pulmonary effusion, where they just start gaining they start acquiring fluid between the layers of the lungs. So the right side is one of those caseous type abscess cases. This patient was not able to just surround and attack that bacilli, but the bacilli would have overran that inflammatory process, caused necrosis to occur, developed a larger area of infection. Those infections then sort of fused together and created these multiple areas of caseous reaction. Now, secondary tuberculosis occurs from a previous somebody that's had tuberculosis in the past. It was apparently taken care of or inactivated and surrounded by a tubercle, which kept it contained. And then through some change in the physiology of the patient, maybe due to a decrease in immunity, that infection becomes reactivated. And with this secondary tuberculosis, oftentimes you will see it go right to the caseous period, cause a lot of fibrotic changes in the lungs, cause a mediastinal shift, and different things like that. So that would be a secondary case of tuberculosis. Miliary tuberculosis is when you actually have lots of tubercles spread diffusely throughout the lungs, and this can actually affect the GI tract as well as just the lungs. So what it is small areas of bacilli that are then encapsulated in an inflammatory response, creating many small tubercles. Pulmonary mycosis is a fungal infection of the lungs, and we have two different types that are common in the United States or North America. And the first is histoplasmosis, which comes typically in the Mississippi and Ohio River valleys. The second is coccidioidomycosis, which is more common in the southwestern United States. Now, either of these, the fungal infection is introduced to the lungs, and what will happen is usually patients do pretty good to start with, and then they can kind of experience some fibrosis of the areas of infection. So wherever that fungus is settled into the lungs, you'll see a reaction called a granular reaction, where the reaction causes fibrosis around the infection itself to try and hold that infection in place. What will often happen is then that gives it the appearance similar to a miliary tuberculosis infection. Now, these mycosis pathologies can also spread to other organs. So you might see these small granular reactions in other organs. Most of the time, the other organs involved are the liver, spleen, and lymph nodes, and that can help them actually with the diagnosis or the differential diagnosis between tuberculosis and pulmonary mycosis. One of the problems with the mycosis is that it can cause fibrous reactions throughout the whole system, which would lead to narrowing or sclerotic changes in the mediastinum and in the lung area. Here you see an x-ray of histoplasmosis. Now, oftentimes histoplasmosis will actually start as one fibrotic area, but sometimes it can spread throughout and take on this appearance that is, like we said, very similar to miliary tuberculosis. Now, this is also a similar appearance that you would see in the liver, spleen, and other organs if it were able to transfer. Most of the time, these fungal infections do not affect people with healthy immune systems. They're really opportunistic pathogens, which are going to affect people that have more underlying issues. Just a second to compare histoplasmosis to the coccidioidomycosis and some of the similarities and differences between the two, and really make note of their appearance and remember that they are both fungal. RSV is a common virus in young children, especially under the age of 2. It's the most common cause of bronchiolitis. RSV attacks the lower respiratory system. It's caused by a viral infection, which can cause necrosis of the endothelial or inner lying tissue of the lower respiratory tract. Because of that inflammation and the necrosis, it can then go on to block the bronchial tract, which would result in further infection, bronchial spasms, and then lead to interstitial pneumonia and can cause obstruction. This is highly contagious through droplets, and the symptoms are not often recognized as anything other than a common cold. And so nosocomial infections caused by RSV are typically common. RSV is noted as hyperinflation of the lungs and can, in extreme cases, be demonstrated as interstitial pneumonia. This is typically can use a variety of treatments depending on the severity of the case, and it can range from no treatment at all to intravenous antibiotics to inhaler type medications all the way to intubation. SARS, or severe acute respiratory syndrome, originated in China in the early 2000s, in about 2003, and its etiology is that we know that it's a form of the coronavirus, but where it came from is still unknown. This has about a 3% fatality risk, and it can be a very dangerous respiratory infection transmitted by direct contact or droplet contact. Unlike RSV, SARS will appear on our images as an area of focal infiltrates later in the disease process. Early on, they may actually have a normal chest x-ray. Treatment for SARS, if they are able to survive through the 7th day, they typically survive the disease. Death usually will progress or occur prior to that. This brings us to the classification of diffuse lung diseases. And diffuse lung diseases are diseases that don't affect just one area of the lungs, but affect the whole lungs or the whole respiratory system itself. So the ones we're going to talk about today are chronic obstructive pulmonary disease, or COPD, sarcoidosis, and pneumoconiosis. Chronic obstructive pulmonary disease, or COPD, is common and we see it very frequently as radiographers. COPD includes several different conditions. So asthma, emphysema, and chronic bronchitis all fall under the COPD umbrella. Now, some cases of COPD will actually have a patient that has multiple of these diseases within the COPD diagnosis. So when we look at chronic bronchitis, what happens with chronic bronchitis is it typically affects those that are exposed to long-term cigarette smoking or air pollution. So with chronic bronchitis, the body's reaction to that damaging insults is to produce more mucus. So over time with chronic bronchitis, the body produces more and more viscous mucus, and the patient has to cough to keep that cleared out. So you'll hear these chronic bronchitis patients coughing, coughing, coughing to try and keep their lungs clear. The second thing under COPD, and it's often coexists with chronic bronchitis, is emphysema. So with emphysema, as the chronic bronchitis develops, it can cause an inability to expel air as efficiently as before. So air backs up into those tiny alveolar sacs. As it does that, those sacs get stretched and stretched and stretched and get thinner and thinner, and they become less efficient at transferring oxygen to the blood. The lungs then get larger and again become less efficient, and you'll see typically flattening of the diaphragm and hyperexpansion of the lungs. Asthma is a little bit different in that asthma can just exist within the patient, but can also be irritated by other environmental factors. Now, with asthma, you will have a bronchial spasm of somewhere in the bronchial tree, the trachea, the main stem, or the tertiary bronchi. And when those bronchi spasm, the patient can't, again, similar to chronic bronchitis, is they can't expel that air. So they're able to breathe in, but they can't breathe out. And again, if this happens frequently enough, it will dilate the air sacs or the alveoli and then could lead to emphysema. You can see that this is a radiograph of a patient with emphysema, and some of the classic signs of emphysema are hyperinflated lungs. They'll take on a radiolucent or more of a black appearance, and they'll definitely demonstrate a flattened diaphragmatic dome. Often emphysema is correlated with cardiovascular effects as well, so you may see cardiomegaly or a large heart in these patients. In this lateral chest x-ray, you see that the patient has a barrel-chested appearance where the AP diameter of the patient's body has increased, and you definitely can appreciate the flattening of the diaphragms with this significant case of emphysema. One other thing that you may note, as I mentioned, the walls in emphysema, the walls of the alveoli thin and they can rupture, and multiple alveoli can join to form one sac. Those ruptured alveoli forming one sac together are known as bullae. And sometimes you'll see bullae throughout an emphysematic chest x-ray as sort of a large air-filled space. Now, this is an excellent example of a CT of a patient with emphysema. On the patient's left, you see that there is some normal alveoli structure where you see that those low-level radiopacities on the left side. On the right side, you see that those alveoli have mostly ruptured and become a large bullae. And when that occurs, there's not going to be any blood-oxygen exchange between the lungs and the capillaries in that region. Asthma, as I mentioned, is the restriction or constriction of the bronchial tree, and it's usually caused by some sort of allergen or other outside factors. However, sometimes it can come from internal factors such as exercise or emotional states that will cause that constriction of the smooth muscle of the bronchial tree. The other thing that can happen is while it's constricting, it can increase the mucus production and make that breathing out or the exhaling even more difficult. Now, on the radiograph of an asthma patient, if they're in between acute asthma attacks, you may not notice any differences. If they're in the midst of an asthma attack, you might see the dome flattening of the diaphragms. And if they've had long-term asthma, you can start to pick up some scar tissue throughout the lungs. One difference between asthma and emphysema is usually that you will not, with asthma, lose those internal vascular lung markings. So you can see in this patient here that they have a lot of radio-opacity or diffuse lung pattern throughout the entire lungs, unlike emphysema where you lose much of that pattern and they begin to appear radiolucent. Sarcoidosis is a pathology of unknown origin that typically affects younger females, mostly African Americans. And this is a granulomatous disease, and we've talked about granulomas being fibrous encapsulated areas. So sarcoidosis demonstrates itself as granulomas or fibrous encapsulated areas throughout the chest, and can actually also affect other organ systems. This will then therefore appear as defined granulomatous nodules throughout the lungs or other organ system on either X-ray or CT. Often these patients are asymptomatic, and this is found as an incidental finding. To review this slide and the next slide, and maybe take note of one or two unique factors that you can find with each of these diffuse lung diseases. The important part is, first of all, knowing it's diffuse. It's going to affect not just one area of the lungs, but the whole lungs. And then secondly, identify what are a couple things that are unique to each individual pathology. We will wrap up our lecture for the beginning part of chapter 3 here, and you can pick back up with the rest of the chapter on next week's module. Thanks for hanging in there. I know it's a lot of information. Have a great day.